actually worked last time.
Can you guys hear me?
Yes, sir. We can hear you. Hi.
All right, great. Well, good morning.
Good morning.
Yeah. We will get going here in just like 2 minutes. I'm going to give folks just a little bit of time to navigate into the platform here, but so glad to be back to teaching live again. I say live, at least live in Zoom. How are y'all doing this morning?
Pretty good. It's kind of early, but pretty good. I'm glad that we're having class. Sorry, I'm just being honest.
No,
but,
yeah.
But very excited that we're having class. So thank you.
Oh, absolutely. And I typically don't pick Saturdays like this. It's just, wanting to make it up a little bit to kind of catch us up. Just trying to find a time that would catch people at home and hopefully without too much going on. So from here on out, it'll be on Sundays. Yeah. So.
Okay. Thank you.
For sure. Let's see. We're gonna be going pretty swiftly today. Through several topics. I would say kind of just a brief re-review of real brief re-review rundown week 1 and 2 stuff, and then jump into week 3 and 4, also with the realization that tomorrow we'll probably finish up week 4 topics, and be able to progress from there. So I'm going to be opening up those PowerPoints and sharing those. And the reason why I'm going all the way back to week 1 is just it's been a while, and that the break with the holidays, and just wanting to get everybody kind of caught back up. And it might just be us 3, and that's okay. But let's see. That actually may give us a little more flexibility with kind of picking and choosing what we want to cover today. So, does that sound good to you guys? Awesome. All right. Well, let me share my screen. Jump into the review of week 1 and 2 real fast. And week 2, the neurodevelopmental disorder stuff, that is covered extensively in child and adolescent, but I will want to spend some time today talking about it because there's a whole lot of, I would say, TikTok, social media stuff related to ADHD in adults and autism in adults. And so those are really important concepts that I want to discuss. And since it is just us three, I want you guys to feel free to interrupt and to ask questions, because I am very passionate, especially about the neurodevelopmental disorders, and will be glad to address any questions that I can. So a couple things is understanding the brain and brain development, and especially in relation to psychopathology, is we've got a biological system that serves as the foundation of what we describe, I would say, subjectively, or really the term is phenomenologically, in the DSM. We've got a foundation of behaviors and traits that are described in the DSM like that are primarily biological. And as counselors or future counselors, it's important to understand that your job is going to be interacting on the psychological level, which includes cognitive processes, emotional processes, and so forth. But those are the product of the biology. And in order to understand diagnostics, and especially as it relates to what you're seeing in the here and now, and why, what I would say is your clients will report symptoms as filtered through their own psychology. And so if you can understand the biology, it ends up really, really helping you hear what they're actually saying whenever they describe it from their own perspective. Just real quick, I've got one former student at my practice who's now officially licensed as an LPC, and then I've got another former student who just graduated, who is doing his LPCS at the practice. And it's been a lot of fun to work with them in supervision, because they both have talked to me and during supervision time and saying, this information has become increasingly more important as they've gotten more experience working with clients, and mainly because whenever they're interviewing, especially in like intake, they're really concerned about, like, what am I getting myself into here, and do I have the skills necessary to help this person? And a lot of that hinges on their ability to quickly kind of assess and figure out what's going on diagnostically. And so I just wanted to highlight that importance there, because ultimately this is a skill that you will continue building from here on out. And I mean, I have been in the diagnostic world for, gosh, almost 15 years, and I can tell you is I still don't know everything. And like yesterday, I had to Google a certain disorder that I'd never heard of from a medical standpoint. And I mean, it still happens regularly. And so don't feel like you have to get every single bit of this stuff memorized. It's going to feel, especially probably online, a little bit like you're only surface level skimming this stuff, and that's also normal. And that's because there's so much information to learn that even if you had a whole year in this, I'm telling you, it would still not be enough for you to feel real confident. It just takes time. And so I just want you, if anything, I want you to release a little bit of that anxiety and just let your brain be curious about all this information and just absorb it. Just kind of letting yourself, be aware of what is what you know, what you're curious about, and yeah, just absorbing as much as you can. All right. So this is an important piece here that I want to highlight, and then we're going to jump into neurodevelopmental disorders. But our brain acts as, if you think about what produces our thoughts, our emotions, and our behaviors, there are two engines, so to speak. We've got the bottom up engine and we've got the top down engine. All right. And it'll make sense once I describe it like this, because every thought, every motivation, every feeling and behavior results from some sort of compulsion in that direction. And that drive, so to speak, if you want to talk about like Freud's drives, which is pretty analogous to this, starts with bottom up processing, meaning if we look at the brain consists of the brain stem, right? The midbrain and the forebrain. And the cortex, or the outside of the brain, is the top down side. The bottom up side of this is from the brain stem through the midbrain. Now, let me explain, is that, for example, in order for you to think about, I don't know, or in order for you to memorize Erickson's developmental stages, your cortex is where you do that, right? So you're reading, like, let's say you're taking lifespan development, you're trying to memorize all that stuff. Well, you wouldn't be able to memorize it unless you've got, first of all, a heart rate. Secondly, you're breathing and you're alert and awake, right? All of those functions come from the brainstem. And so our cognitive processes start very simple at the lower side of the brain, the bottom of the brain. And as you travel up towards the top of the head, towards the top of the brain, the cognitive processes become much more complicated. But each process is built on the assumption that the underlying function is working. So, for example, and I've had several patients, if a patient has a brainstem, let's say stroke, what that results in frequently is slower, like higher order mental problem solving, even though the rest of the brain is intact and normal. And the reason why it results in slower thinking is because we've got the brainstem that's injured first as the foundation, which slows the rest of the entire brain down so that even that person's intentional thoughts, and even if they try to make themselves think faster, they can't. Another good example of this, and this is actually pretty interesting. So there's a feedback loop from our heart to our cranial nerves that connect in our brainstem, that when you have a heart rhythm abnormality like mitral valve prolapse, AFib, things like that, when you have that heart rhythm abnormality, literally your nervous system will tell your brainstem that you are dying. And what happens is your brainstem sends a red alert up the chain, and before it becomes consciously perceived, before you're even aware or have any thoughts about what's going on, it passes through your limbic lobe and your midbrain, which is your fight or flight center. And so oftentimes people with heart rhythm abnormalities are more susceptible to experiencing panic attacks because their heart will send a signal to the brainstem. Something's wrong. The brainstem, because it's very primitive, it doesn't think, it's just like all or nothing. It says, well, we're dying, and sends that red alert to the rest of the brain. And by the time you become consciously aware of what you're physically experiencing, there's already a stress response and a fight or flight response happening, that's revved up your entire system. That's really one of the best ways I can describe what bottom up processing looks like. Another example, real quick, is our so here's a great example. OCD, which we haven't talked about yet, is composed of two things: obsessive thoughts and compulsions, or compulsive behaviors. Where those come from are the midbrain. And the midbrain is the basal ganglia, it's the thalamus, the hypothalamus, and I would say for the most part of the amygdala, hippocampus, the limbic lobe, the emotional processing center of the brain. And the midbrain, being where OCD is located, it's built in. So in other words, OCD is built into our brain on purpose because we need to have a system where we obsess about water when we become dehydrated, to the point that we become compelled to seek water, right? Can you imagine if we didn't have that? We would not live very long if we didn't have an OCD like drive that would compel us whenever we became dehydrated. The same goes for eating. In fact, the parts of the brain that I'm talking about that deal with those drives, like your thirst and your hunger, and even procreation, like sex drive, all of that same part of the brain is the same part of the brain that is dysfunctional in the brain of somebody with OCD. And I'm using that as an example of bottom-up processing because those are primitive drives or survival-based kind of drives coming from our lizard lobe, that if we didn't have those, we would not be able to plan for retirement up here in the cortex. We would not be able to, navigate a used, car purchase. In other words, we need these lower drives as foundations that push us towards survival. But the problem is, and what separates us from animals, or I say animals, what separates us really from other animals, most animals, is that if you don't have a whole lot of cortex and it's just this brainstem and the midbrain, that's what a lizard is. So most animals, and especially like reptiles, don't have a whole lot of cortex. Some of them do, and some have a lot, but most don't. And the ones that don't tend to be a lot more stimulus bound, where, if you put food in front of them, they will impulsively, compulsively eat it, even if they're not hungry. If there's not any there doesn't appear to be any higher order reasoning or forethought, planning, anything like that. That is the limbic lobe, and every human being on the planet has those same traits driving their motivation, thoughts, feelings, emotions, behaviors from the very moment they wake up to the rest of their life. Now, what separates us again from animals is the fact that we have a whole lot of outside cortex, and cortex is the top-down processing. Top-down processing is where, instead of being obsessed and compelled to eat chocolate cake, because that's what my midbrain wants to do, I now have the capacity to inhibit that compulsion and think through what might be a better decision in that moment as I anticipate the future. So anticipating the future, by the way, is primarily a cortex function. That's an example of top down. So we've got bottom up pushing us, and we've got the cortex where you are thinking your thoughts and having these higher order, reasoning and judgment. Both of these are in a tug of war for our entire life. The more stressed we become, whether that's physical stress or psychological stress, the more stressed we become, the more our bottom up processing takes over. In other words, the more the bottom up processing wins the tug of war. The less stressed we are, the more the top down processing wins the tug of war. Right? That's why people always talk about, I really want to take a vacation to reflect on this, or to spend some time thinking about this. In other words, I'm going to take away all the stressors so that my cortex can actually win the tug of war for a little while, and I can do some introspection rather than, it's Christmas time and we've got 7 places to be today, and I've eaten 12 pieces of pecan pie. That is the bottom up processing. That's also, by the way, why people tend to overeat around holidays, is because we've got a whole lot more of our limbic lobe activated and the bottom down processing working than we do the top down stuff. Isn't that interesting? Yeah. I'm going to pause right there before I switch to talking through neurodevelopmental disorders. But what questions do y'all have about that?
Actually, Dr. Armstrong, that's so interesting. I really, really need to let that process. I'm not sure whether I have a really good question or something that even makes sense. You know what I mean?
Sure. No worries. No worries. And the other example that I forgot to mention that I want to that I do want to mention is how this relates to counseling specifically is you guys have probably all heard of deep breathing techniques, right? So if somebody is having panic attacks, um, we would want to teach them things like progressive relaxation, where you learn how to control the muscle tension of your body, and deep breathing techniques. So what that's doing, well, let's use that as an example. When you're having a panic attack, that means your brainstem is making your lungs and your respiratory rate increase because for whatever reason. And so you've got a whole lot of like energy flowing up, telling the rest of the brain, hey, there's something bad happening. So we need to be on fight or flight mode. That message goes from the brainstem to the midbrain, specifically, really the amygdala. And the amygdala says, well, I guess this is it. It's time for fight or flight. It gets revved up energy wise and kicks off the process of fight or flight, right? And what that ends up doing is causing you to subjectively feel extremely anxious, panicky, psychologically stressed out. Deep breathing, what that does as a technique, if we teach that to patients, that is forcing the outside of our brain, the cortex, particularly the frontal cortex and orbital prefrontal, to push back against that energy by consciously taking control over the brainstem. So the brainstem wants to make you breathe faster and faster and faster and faster. I mean, and if you hyperventilate, by the way, that does set off a stress response. Deep breathing consciously goes back and teaches and turns that signal off or turns it down. And thereby we've got this top-down approach that we're essentially teaching our patients to gain control over the biological aspects or the biological unconscious drives, the unconscious drives, which are creating the panic symptoms. And if you think about it, most therapies, it's really the same concept where, even if it's existential therapy, but cognitive behavioral therapy is probably the best example, where we're teaching how to restructure our thinking and our behaviors in an effort to turn down the signal or the drive coming from the limbic lobe or below. Okay? All right. I know that's a lot just by itself, but
Dr. Armstrong,
yes.
I had a question. It was very interesting. You talked about the animals and impulse control between like us and lizards. I wondered if there any study between criminal behavior and impulse control, how it relates to the study of their behavior and be able to control their emotions, and how it relates to possible the propensity to commit crimes, and difference between those and the ones who are able to control those impulses.
I'm very glad you asked. That's a topic that I'm particularly interested in because I do a whole lot of criminal forensic expert witness testimony. And so, yes, there's a lot of research on impulse control, like engaging in really what would be defined as antisocial behaviors, or criminality, and especially as it relates to certainly a wide range of disorders affecting the frontal lobe and its connections to the amygdala. And, you know, I would say, to summarize, it starts with I would say, a little bit of genetic predisposition, meaning that we come from genetics that have passed on to us a tendency for having weakened wires between our orbital prefrontal to our limbic lobe. And from there, we have the genetics. We've got trauma is often one of the most common. Having experienced trauma during early childhood in particular is one of the most common historical experiences for criminals. And we know that trauma, being a stress response, degrades the strength or the integrity of the wiring between those two places. And then for kids, what it does is it changes and impairs that and makes it weak, not just like short term, but like it teaches the brain to develop a weak connection there. And so, and by the way, that same connection that I'm talking about from orbital prefrontal to the amygdala, that's the same area of the brain for ADHD, which is why trauma and ADHD go hand in hand almost with kiddos for that reason. But as it relates to from there on out, then we have the psychosocial like pressures, and it becomes more of a social psychology factor as we go from genetics to, you know, trauma, early life experiences, or just childhood trauma in general, and then the social milieu, so to speak. When you add all those three together, that's the product of criminality. And I'm telling you, I'm not saying that like people shouldn't be held responsible for what they, you know, crimes, but the courts don't want to really recognize. It's not that they don't recognize, they do recognize it, but they don't want to recognize the ideas that a lot of these things that we are, you know, prosecuting are the product of either a system or a brain that was given to this person that they didn't choose. And it's unfortunate. And it really, yeah, I do about 50-50 on prosecution versus defense, but I tend to do, prosecutors tend to not like me. They don't want to hear me say stuff like that because it takes away culpability in a lot of ways. But the reality is I've never met one person, and I've evaluated death row inmates down there in Huntsville. I've never met one person that has ever woken up and said, you know what, I think I'm gonna be a psychopath, and I'm just gonna be an evil person from here on out. I've never met that person, nor have I ever met that kid that you always, you know, you hear like in stories that is the psychopath kid. There are definitely genetic predispositions sometimes, but I'm telling you, I've never met a kid without a pure heart. It's just that turns into a lot more once you start adding all those other factors into it. And I'm telling you, trauma is a big one, which is why when we're doing what we're doing is so important as counselors, because we have the opportunity to change that trajectory. Yeah. Hopefully, does that answer your question?
Thank you.
Yeah, absolutely. Let me share my screen here. Yeah, and I would say tomorrow night, we will probably, because we're going to only have time, I say only, I really want to spend the rest of our time today talking through autism and ADHD in adults. And so tomorrow evening, we will cover schizophrenia or the psychotic disorders, depression, and bipolar. Because really and truly, that should all be lumped together anyway, those three, because it's really the same. It's really the same phenomenon. Does everybody see that okay? IDD, ADHD, and autism? Yeah. Perfect. All right. Who has seen all the TikTok stuff lately on ADHD? I say lately, the past 2 years, really. Has anybody noticed? There seems to be like everybody's on TikTok, or everybody out there is now saying they have ADHD. Nobody has? Okay. Well, just so you know, the prevalence rate for subjective complaints of ADHD has like I have a friend that's doing some research, and they were sharing with me some of their preliminary data since the start of COVID. The prevalence rate for subjective reports of ADHD or self-diagnoses of ADHD have increased by over 400% in adults 18 and over. And that's being attributed to exposure to social media platforms such as TikTok in particular, and not just ADHD. There are several of them. Yeah. Yeah, Sarah, the neurodivergent stuff. That's another one. Yeah. I wouldn't even really. I mean, you're adults, you can do it, but I hesitate to even encourage you to go on TikTok to search ADHD adult as a search line, because there is so much out there now. And on the one hand, I'm really happy because it means there's a lot of expansion of mental health awareness. But on the other hand, there's just a whole lot of misinformation, and everybody and their dog now is on there saying that they have ADHD or autism. And what you need to know, I'll try to summarize what I really want to get to today, because there's so much there. Is one, ADHD is a neurodevelopmental disorder, meaning that if you don't have ADHD through childhood as a teen, you're not going to have it when you're an adult. You don't have an onset of it. Now, you might have an onset of symptoms of it as an adult for various reasons, but if it wasn't present during childhood and adolescence, it's not called ADHD in adulthood. What do I mean by if it wasn't present? All right. Because I wasn't diagnosed with ADHD until I was in grad school. So that already kind of contradicts what I just said, but let me explain. And to answer a question on the chat real quick, that 400% increase, that was just for ADHD in adults. I'm not sure what, but I bet it's pretty similar. I bet it is. And so the symptoms of ADHD, as you read them through the DSM-5, those are not specific for ADHD. I want you to remember that. The symptoms of ADHD are not specific for ADHD, meaning many different diagnoses, both psychiatric, the mental health stuff, and medical diagnoses, physical illnesses, injuries, disease, can produce ADHD symptoms. On top of that, we have a system designed with education and so forth that, I'll be honest with you, is not science-based. In other words, the curriculum that we have, outlined from TEA every year for kiddos, and historically, why do we start school at a certain time? Why do we end school at a certain time? Why do we have homework and so forth? All of those decisions are not based on what we know about the brain. In fact, most of it goes against what we know is best for the brain. And I hate to be the bearer of bad news there, but I've got an 8 and a 5-year-old, and so I'm philosophically battling all that stuff myself. And so we've got a system also that contributes or can exacerbate what might be, or what may or may not be, the pathology of ADHD. It might, in other words, it could be a systemic phenomenon that could be worsening. On top of, we've got ever exponentially increasing technological advances that seem to be outpacing our brain's ability to adapt. Now, I want you to hear me clearly on this. I'm not saying that watching too much TV or playing too many video games or spending too much time on Facebook is causing ADHD. It is not. Okay? Now, can those things exacerbate it? Absolutely, in the same way that chocolate cake can. But they are not causing it. And then on top of that, we've also had COVID, right? And what we now know with COVID from a neurovascular standpoint is almost every single person who ever caught COVID, no matter how severe it was, kids included, COVID made it to the brain and to some extent has disrupted the vasculature of the brain. In most cases, in the vast majority of cases, that doesn't produce any long-term anything, because there's some, catching a cold can disrupt the vasculature of the brain. But we've got all these other factors here too that have added to this rise and what seems to be an increase in prevalence. And I would say less physical exercise, poor eating habits, in addition to like sleep disorders increasing, and just general stress, and probably several different environmental factors that we haven't quite pinpointed, but might be related to microplastics and things like that. Okay, so going back to my point here is that ADHD is a neurodevelopmental disorder that begins during neurodevelopment, meaning the pathology is present And the DSM-5 requires that you have functional symptoms present. I think, what do they use? The cutoff, it's age 13, I think, or 12 or 13. That if you're, let's say you're 30 years old, you go in there to talk to somebody to get diagnosed with ADHD. If they're going to follow the DSM-5, they would ask that person, okay, well, tell me, did you have any of these symptoms before age 13? And a lot of times adults don't. And technically, that would disqualify them from having ADHD. But I want you to know is that it's possible for people to have the underlying pathophysiology of ADHD during childhood and adolescence, but for them to not have symptoms of ADHD until adulthood because primarily of environmental factors that were helping them compensate. And I'll give you an example. I see a lot of college students that are coming in their first 2 years of college, and they get referred to me for an ADHD evaluation because they have failed out of college, and despite being a straight A student through high school. And what ends up happening a lot of times is that adult or that young adult had a whole lot of external support and structure provided for them, usually a parent acting as a surrogate frontal lobe, helping them plan, time manage, helping them make sure they're turning their stuff in on time, waking them up in the morning, so forth, right? And then all of a sudden they take this leap from high school with all that support to college and not having that support. And it's not the academics, it's almost never the academics that they can't handle. It's the personal responsibilities that exceeds their ability to cope. And now their symptoms of ADHD become present because they've lost all their support. That is the explanation of adult onset ADHD in most cases of true ADHD. Now, when you hear the term adult onset ADHD, I want you to think of two things. One, this person might have had ADHD their entire life, except it's just now showing up because some stressor is the straw that broke the camel's back. And now they can't compensate for it anymore. And so their symptoms have shown up now. I want you to remember that that's a possibility. And then I also want you to remember that there's a better chance that something else is causing what appears to be ADHD symptoms. And if we diagnose ADHD and don't pay attention to what it could have been, it's never going to get fixed. So for example, sleep apnea in adults looks just like ADHD. Another good example, moderate to severe depression will look like ADHD. Generalized anxiety disorder will look like ADHD. Bipolar, and several, I would say, hypothyroidism, even in older adults, early onset dementia, vascular dementia, stroke, traumatic brain injury. There's a million other things that can look like ADHD in adulthood. And that's where I want you to start, while also keeping in mind that it is possible that they had it their whole life. It never really showed up until now because of this extra stressor pushing them beyond their limit to cope. Okay. Now, what is ADHD? And like the underlying pathophysiology is, I would say, I would describe it this way: is we've got a frontal lobe system being built from day one that doesn't stop being built until we're around 2025. What that means is all the wires that, if the frontal lobe is our judgment, planning, prioritizing, organizing, self-reflection, emotional regulation, impulse control, if that's what our frontal lobe does, in addition to other stuff, all the wires that tell the rest of the brain how to do those things, the wires are what are developing the rest of our life. Okay? I say the rest of our life. The wires are what are developing from conception to age 25. So that's what I mean when I say the frontal lobe isn't fully developed. It's not really the frontal lobe. The frontal lobe is, if you looked at the frontal lobe, at age 8, it looks like frontal lobe, but it's the wires, the white matter isn't fully mature yet. Now, we know that the white matter, the brain, the cells of the brain, communicates in electrochemical manner with neurotransmitters. And the cells of the frontal lobe, the neurons, use the wires, the axons, and send signals to the rest of the brain using dopamine and norepinephrine primarily as neurotransmitters. Okay? ADHD is a disorder that affects the neurotransmitter system of the brain such that dopamine and norepinephrine don't work as well, and in some cases works too well. Okay? And that your brain doesn't know how to use dopamine and norepinephrine at its maximal level until about age 25. In other words, until then, it's still learning how to use it, right? And that means that intervention for things like ADHD in childhood will result in a decreased risk of having ADHD in adulthood, because there's a possibility that we might course correct and help the brain say, okay, we're doing it wrong. Let's start doing it this way. And when we're 25 or whatever, the day of final development, it looks like a healthy brain or normal adult brain without ADHD. In fact, the research supports the appropriate use of medication in kiddos with ADHD. And when that's done correctly, their frontal lobes and the connections, the dopamine norepinephrine connections, look a lot more like their peers without ADHD when they're adults. And it increases the chance that they will grow out of it and not need medication the rest of their life. If you're an adult with ADHD, you can't go back in time and reteach your brain how to appropriately use dopamine norepinephrine. It just is what it is. And in fact, it's just a system that's starting to degrade. So you hit the peak at age 25, and there's just a slow decline after that. And so if you're an adult with ADHD, if you want it to be treated, medication will be necessary, but that doesn't mean it's always necessary. And I'll say this real quick, and I'm going to have to be mindful of our time because I've got another class coming up right after this one. But let me say this, is that ADHD and all of these things are only diagnosed when they cause dysfunction to our daily life. And so if let's say you were a billionaire on an island that you own in the middle of the Pacific and didn't have to worry about working, and you had all your family out there and you had every need met, and all you had to do is wake up every day and casually walk to your beach bed and, read your favorite book and watch the dolphins jump out of the water, right? Even if you had the underlying pathophysiology of ADHD, in that scenario, it's unlikely that you would have enough dysfunction in your day-to-day life to be diagnosed with ADHD. Okay? So it's not a matter of do you have it or not. It's really a matter of if you have it, is it causing a level of dysfunction worthy of treatment? And if it is, that's when a diagnosis is necessary. And at that point, that's when medication and treatment will be necessary. Okay. And Greg, yes, I can absolutely post this video and the other one I think I recorded. Can't remember if I did or not, but okay. Let me pause us there. And I know we didn't get into autism yet, but we do have class tomorrow. I think that's at 5 p.m., right? Everybody remember that? Let me confirm that. Yeah, yep, that's at 5. So for those who kind of joined later, tomorrow we will be covering autism. We'll probably rehash ADHD a little bit, but we'll cover autism and the psychotic disorders, depression, and bipolar, because that's all the same lecture. It's all kind of grouped together there. Okay. Questions related to adults with ADHD. Anybody have any? Yeah. Sure. Go ahead, Greg.
No, I said no questions.
Oh, no questions. Gotcha. So in the PowerPoint slides, there is there's a PowerPoint slide called the Advanced ADHD Assessment, and it looks like this. Let's see. I would highly recommend you guys taking a look at it, and because it covers basically the best way to assess this thing and evaluate for it, and as well as a whole lot of resources for it. But I want you to know that, well, I'll say this: if you ever have any questions about ADHD in adults or kiddos too, because in my practice, about 60 to 70% of what I do is related to ADHD. Not 70%. I would say closer to 50 to 60%. In kids ages 3 to 99. But that is my heart and soul and passion, because it affects me. And tomorrow we'll probably talk through the medication side of stuff with it, cover autism, and then move forward with the psychotic disorders, mood disorders, and depression. Sound good?
Yeah, I had a question.
Right. Yeah.
Because you were warning about misdiagnosing adult onset ADHD. Is there a good way to determine the difference between a trauma response and ADHD in children?
In children? So I would say this is that chronic stress in childhood, which can be primarily derived from a traumatic experience or even PTSD, that can be enough to change the developmental trajectory of that dopamine and norepinephrine system such that we have trauma as the primary etiology, but we also have ADHD. And in fact, most kiddos that I evaluate who have PTSD have ADHD. And does that mean that they're going to have ADHD the rest of their life? No, it doesn't. Does it mean that if we treat the trauma, that it will automatically treat the ADHD? No, it doesn't. Because what you need to know is that the dopamine and norepinephrine system is highly dynamic, and once it learns a pattern of firing, it really likes to use that as its average from there on out. So the more, like, let's say you can either fire ADHD or non-ADHD, and the more it fires in the direction of ADHD, the more that becomes its average. And so even though it could have been a trauma that initially caused it for a time to fire towards ADHD, that pathway is now learned. And even if we treat the trauma, there's still going to be treatment necessary for the ADHD. And so I'm not a big fan of trying to separate the two. It really doesn't make a whole lot of sense biologically. And I say trying to separate the two. I separate the two there categorically, but clinically, it matters in as much as I don't want, well, let me just tell you what I think is important. There's a lot of people out there that'll say, well, if we just treat the trauma, then the ADHD will go away. Or this isn't ADHD, it's actually just trauma. Well, you can't really say that because it's the dopamine norepinephrine system and its complex and dynamic interaction with the stress response system that the answer to that is it depends. If this is a 17-year-old who's had, recurring trauma since age 5, I can almost guarantee you that they have ADHD, and that you can treat the trauma, and even our treatment of the trauma, just so you know, is not a cure. They're still going to have they're going to have an extra oversensitive, like, trauma response the rest of their life. The treatment, what it does through therapy especially, is it gives them stronger connections between their prefrontal lobe and the amygdala so that they can consciously be in more control over that drive. And so anyway, my point here is that I don't want folks thinking that, because that's like a kind of a meme in the mental health world right now, is, all these kids getting diagnosed with ADHD and treated for ADHD, when in reality it's just trauma. No, it's probably wrong that nobody ever paid attention to the trauma, because that's very important. But don't throw the ADHD diagnosis out whenever we've got trauma, just because those aren't necessarily completely disconnected. Okay?
That makes sense. Thank you.
Sure. All right, folks. Well, I'm going to hop over to my other class, and then I will post this as soon as I wrap up with my next class. I'll let my computer download all the video stuff, and then it takes like 30 minutes, and then I've got to upload it into Moodle, which takes 30 minutes. And so I'll get it uploaded for you guys y'all who want to watch it again. Okay. All right. Y'all have a great rest of your day. Absolutely. And we'll see y'all tomorrow.
Thank you.
Thank you.
All right. Take care.